So for the next 20 to 30 minutes, we're going to learn about migraine headaches, which is perhaps the most common lifestyle-limiting symptom that some of you in the room may be experiencing, both for FMD and SCAD. So very relevant, important topic, a lot of questions about this. So I'd like to introduce Dr. Makki, who's a neurologist and a migraine expert. And he's going to share with us his thoughts and expertise and his time. I appreciate you being here. Thanks so much.
Thank you. Thank you so much for having me here. It's an honor. This is my first year back at Emory and the symposium. And I'm glad to be talking about a subject that is very dear to me, that's migraine and its connection with vascular disease. I think this is the hardest lecture I've given because I'm coming after Dr. Wenger. If I have the choice, I will listen to her again rather than me. Really, it's starting with my disclosures. I've worked with migraine medications for a long time. Did some of the original trials of the newer medications. So I do consultancy work and speaking for multiple of those therapies that I will be discussing today, and this is, of course, before Emory. The other interest that I have to disclose is that I got some slides from Dr. Wells. So today I'll, after this lecture, I will hope to convey to you a few objectives. First, I will explain to you how do we diagnose migraine a little bit. I will discuss the significant coexistence of both migraine with FMD and SCAD. I will also touch on newer therapies and a little bit about the approach that we follow to treat migraines. So we will start by discussing numbers, how common is migraine in FMD and SCAD. We will then discuss a little bit more numbers about how common migraine is in the world and other than in other patient population. Then I'll talk to you about how do we define a migraine, talk to you a little bit about the newer way of understanding of migraine that has changed completely in the past decade, and then talk to you a little bit about treatment. The story of presidents and migraine is very fascinating. A lot of presidents had migraine, and President Wilson actually, very shortly after he became president in 1913, his buddy and golf partner was his cardiologist, and he actually prescribed daily golf for him. And actually, interestingly, he mentioned that golf was necessary form of exercise for Wilson to battle the anguish of stomach cramps and migraine headaches related to a heart condition. So that connection, even at that point, somebody did the connection between heart condition and migraines. In fibromuscular dysplasia, neurological symptoms are very common. Not just headaches, but there are multiple other symptoms and conditions that are associated with it. Around 50 to 65%, depending on the studies, of patients do report some form of headaches. And if we look at the largest registry for patients, around 67%, I'm sorry, believe me, I'm reading from the slide, so I'll tell you if you can't see it. So around 67% of patients did have headache in that registry. And those patients usually tend to be younger, on average around 5 to 10 years younger than the patients without headaches. Those patients also have strokes more commonly than patients without headache in fibromuscular dysplasia, almost double the rates. Typically have more frequent headaches. So around 50% of patients with fibromuscular dysplasia who have headaches have frequent, daily around the quarter and weekly around the quarter. And again, the majority of them don't have just a regular headache, they have a migraine headache. So we think about headaches as a big umbrella, and there are multiple different subtypes of headaches under those. commonly it's migraine, and I'll give you some hints and ways that how we differentiate migraine from a regular headache. In addition to that, those patients commonly or much more commonly suffer from depression and anxiety. So those who have a headache out of the fibromuscular dysplasia have more depression than fibromuscular dysplasia patients who don't have headaches. In general, patients who do have fibromuscular dysplasia, many of those have the disease affecting the arteries of the brain. Actually, more than 3/4 of patients do have some affected cerebrovascular circulation. And in those, if you also divide them into those with headaches and those without headaches, almost all the symptoms are more prevalent in patients who do have headache. So we don't like in medicine to use marker of disease, but if you want to think about it, it's like you select those with migraine, and then most symptoms would be more prevalent in patients with migraine among those who have fibromuscular dysplasia. So just when we see those numbers, we always in science raise the question, are they connected? And migraine has always been thought as a vascular headache. Actually, when we learned medicine, the code to code migraine was similar, vascular headache. Things change, and I'll tell you about it in a minute. But unfortunately, there was no true investigation in the community to see truly how much these two entities coexist. We always look at it from a starting point of fibromuscular dysplasia. We look back, see how many patients do have a migraine. But we don't have true association studies in the population. We also don't have true association studies from a migraine standpoint, looking back to see how many of those do have fibromuscular dysplasia. I'll switch gears to SCAD a little bit, to spontaneous coronary artery dissection. You've learned a little bit about it here. It's predominantly in women, which also is a migraine quality. Migraine is more prevalent in women. It is also relatively in the younger population. If we do the same exercise and look at a SCAD patient population, around 40% of those do specifically report migraines. There's also a lot of FMD in this subtype of population, but it is also a very common and prevalent problem. Those patients also tend, I'm sorry, but so those patients also tend to be on the younger side, similar to the FMD population. So if you have a headache, you're probably younger in the SCAD population. And they do have a little bit more frequent headaches, though the frequency is not as frequent as the fibromuscular dysplasia patients. Those usually, on the majority, around 50%, report once to twice a month headache, versus, remember, 1/4 of the FMD patients report daily headache almost. So some other studies also showed similar numbers, but less frequent than a monthly, so headaches in almost half. Thankfully, that in patients who have migraines, they are not at a higher risk of recurrence of their SCAD if a SCAD happens. So it might be that SCAD happen more in a migraine patient, but it doesn't mean that it's going to happen again. So after an event, at least. So again, when we think about the connection between vascular disease and migraine, things come to mind that we see very commonly in migraine patients in general, even those who are not recognized to have fibromuscular dysplasia or coronary artery dissection, are prone to other vascular conditions. Aneurysms, you heard about it this morning. Retinal vasculopathy is very common, so problems in the arteries of the eye. And not only that, but the physiology of migraine patients, the arteries seem to be a little bit stiffer in the aorta. But those are all suggestive studies. We don't have a correlation truly. lately there are some genetic studies that show that maybe there are some shared genes. But in medicine, we're very cautious about these findings. Those do not mean causality. It doesn't mean that this gene causes both entities. It just means that there's maybe some connection in between these two. Though this, the idea of migraine being a vascular headache comes, from what? From a migraine is most of the time a pulsating headache. Boop, boop, boop. What does boop, boop in the body? It's the heart and the vascularity. So it's very logical that, and this has been a carried over theory that was completely debunked in the past 15 years probably. And actually, and there was a slew of articles completely debunking this, and it was more and more evident that the arteries are really just a small link in a much bigger chain of a problem. And it's in migraine patient, it seems that there is a little bit of a hyperexcitability in certain areas. Some other people called it dysmodulated. That means, there's maybe a little bit of an imbalance, if you want to think about it. And the idea of this trigeminal system, you've heard of trigeminal neuralgia, so all head and neck pain, everything that has to do with pain from the neck and above is mediated through a system that we call it the trigeminal nerve. So it is now we think of that system as being very excitable in migraine patients. And there was a very lucky finding that a small molecule that is central to this system called CGRP that was found to be very prominent and produced heavily in migraine patients and during a migraine attack. So researchers rushed to block that molecule, which brought in a complete new generation of treatments. We discussed this about the artery being just the innocent bystander. I will again shift gear now to talk purely about migraine a little bit to you. Migraine has been reported in history as early as ancient Egypt. And the name comes from Greek, mikran, half cranium, migraine. That's how the term. Because most headaches are many times hemicranial, or happens in half of the head. But it's not true, and I'll tell you in a second about it. So there is no test to diagnose migraine. It's a story. We listen to the patient. And this story was kind of regulated a little bit into some guidelines to diagnose by the International Headache Society. To think about it, in order to diagnose a patient with migraine, he or she needs to have 5 attacks, and typically the attack, typically the attack is 4 to 72 hours, and it needs to have 2 of those characteristics, either on one side, but it can be on both sides. Because if you think a headache on both sides that is throbbing and severe, this is a migraine. So it doesn't always have to be on one side. And I see it with patients. Sometimes they hold on treating with the migraine-specific medication because, doc, this attack was not on both sides. But actually, even this attack that was on both sides is a migraine. Okay, then it needs to have a little bit more than, or another symptom, either photophobia, that means light bothers you, or sound bothers you, or it needs to have nausea or vomiting. But it doesn't have to have all of these together. And then if it's accompanied with some other symptoms like visual problems, we call it migraine with aura. So I see many, many patients who come actually and diagnosed with tension headache because it is a moderate headache that happens on both sides, and everybody tells them, no, this is not a migraine, and hence have not treated them with appropriate migraine therapy because of this. And what truly the headache attack is the tip of the iceberg. The physiology of migraine is a very complicated physiology. That 4 to 72 hours, it's just literally the tip of the iceberg. The physiology starts days before and can last days after. For those of you who have migraine, know that maybe 2 days before, or some of you, will start yawning, have low energy, I'm irritable, and I can't eat, I have a little bit of constipation. And then 2 days later, I have the attack, and then for a day afterwards, I'm very sleepy, I'm very tired, I still have nausea and can't eat. So truly that ictus, that migraine attack, that headache was just the representation of a longer chain of events. Everywhere in the world, almost, there is 1 out of 10, a little bit less than 1 out of 10 who have migraines. Wherever you see, it's around 10% of incidence. Here in the States, the largest patient population-based study was around 12.5%. And if you get all of our neurological disease, me as a neurologist, all of the diagnoses together, stroke, MS, Parkinson's, dementia, all of them together, they're way less than the incidence of migraine. So it's such a common disorder. The treatment has changed a little bit based on the physiology that I told you. Sigmund Freud had migraine before. Look what he wrote his wife a letter in 1885. He said he woke up with a migraine because he was actually ate a bad tartar sauce. And how did he treat it? Cocaine. With cocaine, actually, which was a common treatment. And guess why? Because it constricts the arteries, which many. And actually, I looked at Dr. Wells' previous slides. Actually, you've noticed. Cocaine is one of the reasons for SCAD, so it's really, fortunately, we don't treat migraine that way here now anymore, We have a much bigger armamentarium of medications that we treat with, and we approach it a little bit in a systematic fashion. First of all, we think about the treatment on 2 different levels. How do we abort an attack when an attack comes, and that's what we call abortive therapy, and how do we prevent further attacks or preventive therapy? The preventive therapy goal is to decrease the number of the attacks and also decrease the severity of the attacks when they come. As you know, if you want to think about it, this is not a bacterial illness that I'm going to give antibiotics to and it's going to go away. 12% of the population have it, so it's almost like a kind of wired, or we have a wiring to have a migraine rather than truly an acquired disease. So it's not, there is no medications that's going to get rid or cure that problem. That's why the goal of preventive therapy is again need to be aimed to quality of life and hence decrease the attacks, severity, decrease the number of the attacks. And the way we approach it is a little bit numerical. So everybody deserves abortive treatment. You need to have something in your hand to take when the headache. And you need to take it early. Because if you wait too long, the headache is much harder to treat. Then typically, if it's less than 4 attacks per month, then we stick to abortive treatment, except in the lower special cases where the attack lasts a week, then it doesn't become an attack a month, it becomes a quarter of the month. Or if the attack has with it severe weakness, loss of certain functions, stuff like that, then we might elect to start on preventive treatment even in less number, in a smaller number of attacks. If it's more than 4 attacks per month, we typically recommend preventive therapy to, like we said, and we'll talk a little bit about that. And if it's more than 15 headaches per month, then it is under the category of chronic migraines that also qualify for certain types of therapies that are different than others. There are multiple classes of medications. This is the general classes, and many of you probably are familiar with that. Everybody in the acute therapy starts with typically some over-the-counter analgesics, but those are many times not effective. Triptans, not here. Number 1. Triptans are very commonly used We use them a little bit less in FMD and SCAD, and I'll tell you because they are powerful constrictors. And the newer ones are GPANs. And preventive treatment have also multiple different categories. The story is a little bit more complex. That's also a simplistic approach. But we find ourselves much more often veering away from the older therapy and sticking to the newer kids on the block, and those are the treatment based on CGRP that I just told you about. These are biological therapies that have an excellent safety profile, and when compared to the older therapies like the triptans, are very effective. 5 of those are available on the market in the abortive domain, and you've probably seen many of those ads now in publications, on TVs, and and 4 injectables in the preventive treatments. Those are 3 of those are pen, that self-injectable. 1 is a quarterly infusion, and the last one of which is an oral daily therapy. But those are now commonly, and I also find myself starting those. Typically, insurances ask for what we call a step therapy. That means in order to qualify for those, because they are more sophisticated and more expensive, of course, they ask us to have failed few ones. But we've had good success in special group population or special patient population, especially those who have had a previous vascular history, to avoid going through the regular medication, especially that we avoid non-steroidals, because patients who have had medication, those medical problems could be on blood thinners. And we avoid also triptans to avoid the constriction of blood vessels. In FMD and SCAD, there's no established guidelines how to treat migraine. Typically, the risk factors should be addressed, and usually they are addressed at diagnosis, stopping the smoking, avoiding triggers, and typically we start avoiding the vasoconstrictor agents, so those agents like the triptans that constrict. Though some of the data suggest that they are safe, I usually err on the side of safety and choose other options. And the newer therapies seem to be safe. Again, general recommendation and pathways in patients who have SCAD is initially at diagnosis, prior to the hospital discharge, when they are diagnosed, to review at least the medication that we are on, or the patients might not have mentioned that they use occasionally for abortive therapy, to stop that medication. We also, like we said, hold all non-steroidals, especially if somebody is on blood thinner, and arrange to follow up as outpatient. And in the outpatient setting, after taking a careful history and seeing how the patient is doing over the past few months, decide whether more preventive therapy is done. And we usually aim with preventive therapy to at least reduce 50% of those attacks. And we would reconsider continuously. Mind you that with time, I learned over and over again that approaching migraine from a pure pharmacological approach is very simplistic. I like to always tell my patients that migraine is a lifestyle headache. It has a lot to do with lifestyle. And if I don't address lifestyle, I'll be completely missing a major part of trying to make the patient better. And you heard a little bit earlier about the importance of management of and the techniques of management of depression and anxiety, which is a huge comorbidity in migraine. And that's why nutritional approaches, self-care approaches, stress management are integral to migraine management. And if I have to stress it, it's almost equal to pharmaceutical management many times, and especially in some patients. I hope I gave you a kind of a quick synopsis over this entity in FMD and SCAD and in general. Thank you for having me, and please, if you have any questions, I'll be more than happy to answer.